Welcome to the Deep Dive. Today we're tackling a concept that's everywhere, but, well, it's surprisingly slippery. Disorder in psychiatry. We're not just looking at textbook definitions. We're really diving into the philosophical underpinnings. What does it even mean for a mind to be disordered?
Exactly. And for this deep dive, we've really immersed ourselves in these fascinating transcripts from Philosophy of Psychiatry Webinars. We've got a huge range of thinkers.
Oh, yeah. Like who?
Well, people like Natalia Washington, Camilla Kong, Lisa Bortolotti, Justin Garson, Jerome Wakefield, Rachel Cooper, loads of others. Each brings a really unique angle to this whole thing.
Okay, great. So our mission, as always, for you, the learner, is to navigate all this complexity without, getting bogged down in jargon.
Right. We want to unpack the different ways disorder is understood, the real challenges in defining it.
And what it all means for how we think about mental health, right? Hopefully there'll be some surprising connections, maybe a few aha moments along the way.
Definitely.
Okay, let's get into it. What's fascinating right away is just how we even start to categorize something as a health issue or a disorder.
Well, that's a huge debate right there. Natalia Washington highlights this tension between thinking in terms of disease versus dysfunction.
Okay, dysfunction.
Yes.
That's like when a biological part isn't doing what it's supposed to do, like its design function.
Pretty much, yeah. A failure of a mechanism to operate as it was, sort of naturally designed.
But Washington points out, and it seems crucial, that both disease and dysfunction rely on what she calls naturalized norms.
Exactly. Which immediately brings up the question, whose norms are we talking about? Who gets to decide what's normal functioning?
And what happens if those norms are used to maybe unfairly restrict people?
Right. And Washington connects this directly to critiques coming out of disability studies. She mentions thinkers like Ron Atkinson, Anita Silvers.
What's their argument?
Well, basically that just because someone has a specific feature, something descriptively specific like paralysis or maybe autism, that doesn't automatically mean it's a negative thing from a health or well-being standpoint.
So different isn't automatically disordered.
Precisely. It's not inherently something to be fixed just because it deviates from a supposed norm.
That's a really powerful idea. And Washington uses the example of homosexuality being removed from the DSM.
Yeah, exactly. That shift wasn't really about finding some new biological dysfunction or lack thereof.
It was about changing societal values, wasn't it? John Green would also mention that, focusing on distress and disability as the key factors.
That's right. The argument became that homosexuality itself didn't meet those criteria for being a disorder. It really makes you think how other conditions might be framed or maybe unframed based more on social shifts than pure biology.
So a big takeaway here is that disorder isn't some purely objective biological fact set in stone.
Definitely not always. And Washington also brings up this really interesting CDC graphic. It shows ADHD rates varying wildly across the U.S.
Wow, really? Why?
Well, the implication is that contexts, things like different school systems, maybe different cultural expectations about attention or behavior, plays a huge role.
So it's not just something inherent in the child. The environment matters.
Hugely. It influences what gets noticed, what gets labeled as a problem or disorder.
Okay, that really hammers home the point about context. Now, shifting gears a bit, Camilla Kong brings in something else vital, the person's own objective experience.
Yes, this is so important. Kong stresses the ethical need, and often it's a legal requirement, too, to genuinely consider the person's own point of view in psychiatric settings.
Like being open to their experience, taking their wishes and feelings seriously when making decisions, especially best interest decisions.
Exactly. It sounds straightforward,
Yeah.
but... Well, Kong raises a really important challenge. She questions the simple idea that just respecting someone's stated wishes automatically means we're respecting their full capacity or autonomy.
I see. So someone might say they want something, but maybe they aren't fully able to weigh the consequences.
Right. Kong warns about the risk of just equating, say, eccentricity with a fully informed autonomous choice. If we just presume capacity without looking deeper...
We could leave someone vulnerable in a bad situation.
Potentially, yeah. Because their decision-making ability wasn't really examined closely enough. Respecting autonomy is more complex than just taking things at face value, especially when vulnerability might be involved.
That's a tricky balance. Does she mention how the system handles that?
She briefly touches on how courts sometimes use something called inherent jurisdiction as a kind of safety net, even when capacity is technically presumed, but there are clear signs of vulnerability.
Okay. Now, related to respecting the person's view, Lisa Bortolotti talks about validation, right?
Yes, and this is so powerful. Bortolotti emphasizes just how crucial it is to validate someone's feelings and their perspective in mental health care,
Even if you don't agree with their view.
especially if you don't agree. It's about taking the time to truly understand their experience, their reality, without jumping to dismiss it, acknowledging it.
It's about saying, I hear you, I understand, this is your experience, even if my experience is different.
Precisely. And Bortolotti makes this great point that this agential stance, respecting autonomy and validating experience, it's not just for mental health.
Oh, where else?
Well, think about relationships with power imbalances. Parent-child, maybe teacher-student.
Oh, yeah. Taking that stance could really change those interactions, couldn't it? If we consistently try to validate the other person's perspective first.
It really could. It's a broadly applicable principle. Now, let's maybe shift to a more historical view. Justin Garson looks at how we've understood madness over time.
Okay, interesting. What's the main tension there?
Garson explores this long-running debate. Is madness primarily a breakdown, a kind of dysfunction, or could it be seen as maybe a strategy or serving some kind of function?
A strategy? Like how?
Well, Garson points back to Freud's early ideas. Freud sometimes saw mental disorders as these deviant but strategic ways for the unconscious mind to fulfill repressed desires.
So not just a broken machine, but the mind actively, if distortedly, trying to achieve something.
Kind of, yeah. And he goes even further back to Robert Burton in the Renaissance.
Burton, what was his take?
Burton viewed melancholy, which covered a lot of what we'd call mental distress now, as potentially a divine strategy, with goals like punishment but also redemption.
Wow, that's a radically different way of looking at it, a divine strategy.
It is. And what's really provocative is the idea Garson brings up that sometimes these states that look maladaptive might actually be necessary pathways to health.
Necessary. How so?
He mentions Philippe Pinel, a key figure in psychiatry, who apparently believed some forms of what they called madness back then were actually crucial steps in recovering from trauma or severe illness.
So the madness wasn't the problem, it was part of the solution or healing process.
In some cases, potentially, yes. It really challenges the default assumption that disorder is always just bad, purely negative.
It really does. But Garson acknowledges the other side too, right? That focusing only on strategy could mean ignoring real suffering.
Absolutely. He notes the counter-argument that you might neglect the genuine health issue, the pain involved, if you only see it as a strategy. It's definitely a nuanced discussion.
Okay, so let's pivot now to the actual concept of disorder. What does Awais Aftab say about that?
Aftab suggests we should maybe think about disorder concepts as, well, historically contingent ways we've developed to talk about things like medicalized distress, disability, risk, harm.
So less about finding the one true definition.
Exactly. He questions if we even need one single foundational definition to justify medical help or intervention. Maybe these concepts are more practical tools shaped by history.
That feels like it takes some pressure off finding that perfect definition. Like it might be a bit of a red herring.
Could be. And Aftab also points out, how hard it is to objectively measure many mental disorders compared to, say, a broken bone or a bacterial infection.
Right, which raises big questions about diagnostic criteria, doesn't it? How reliable are they? How valid?
For sure. And Miriam Solomon adds another layer here, the pragmatic stuff.
Pragmatic,
like access to care, insurance coverage, disability allowances. Solomon argues these practical issues heavily influence how we actually use the term disorder and define its boundaries.
Ah, okay. So whether something gets called a disorder might depend partly on whether that label unlocks necessary support.
That seems to be a big part of it. She uses grief as a key example.
Grief. How so?
Well, the whole debate about whether very intense or prolonged grief should be a formal psychiatric disorder. It's not just about symptoms. It's tangled up with our societal values about loss, about what's normal mourning.
And whether pathologizing grief helps or injures people.
Exactly. And Solomon also mentions this interesting hostage-taking idea.
Hostage-taking? What's that?
It's where the way we frame things, like calling something an injury versus a disorder, might be influenced by other goals, like trying to reduce stigma, or maybe trying to qualify for specific resources or benefits tied to one label versus another.
Wow. So the language itself becomes strategic.
It seems so. The labels have real-world consequences.
Okay.
Yeah.
Now let's touch on something perhaps less familiar, plural identity. Elizabeth Schechter's work.
Yes. Schechter introduces this experience where someone feels they have multiple distinct persons sharing one brain. You hear terms like headmates or systems.
Right. It definitely challenges the usual idea of one person, one mind. What are the key questions Schechter raises?
Well, fundamental ones, really, like what is plural identity? Who experiences it? Is the claim literal, metaphorical, maybe delusional? How do we understand it?
And she emphasizes that for many people, it feels very real, right? Not just a metaphor.
Yes. She stresses it can be phenomenologically grounded, based on a lived, felt experience of there being more than one psychological being present.
Does she talk about the stereotypes? Like in movies?
She does. She contrasts that common stereotypic picture of multiplicity or, really starkly different alters with totally separate lives and consciousness with the reality, which is often much more integrated and fluid for many plural systems. The stereotype doesn't capture the nuance.
And it raises philosophical questions too, doesn't it? Like about other minds.
Absolutely. Schechter applies the classic problem of other minds. How do I know you have a mind? But internally. How can you prove the independent existence of headmates within one person?
Especially when the main evidence is the person's own subjective reports.
Right. It's a real challenge, philosophically and epistemologically. It pushes us to think hard about what defines a person.
Okay, circling back to the DSM for a moment, John Greenwood offered some historical context there too, didn't he? Related to homosexuality.
He did. He reminded us how those intense debates around removing homosexuality from the DSM directly shaped how DSM-3 defined mental disorder, specifically adding criteria like distress and disability.
Ah, so those criteria were partly a result of that specific debate.
It seems so. And he also suggests that putting dysfunction into the definition might have been partly about boosting psychiatry's legitimacy within medicine.
Like asserting a biological basis, even if it wasn't fully mapped out.
Kind of anchoring it more firmly in the medical model, perhaps. But the key point regarding homosexuality was that using distress and disability as the main yardsticks helped argue that being gay in itself wasn't a disorder.
It really shows how the DSM isn't just a static, purely scientific manual. It evolves, influenced by social and even political factors.
Definitely. Which connects to a broader concern Awais Aftab brought up over medicalization.
Right, the idea that medicine's domain keeps expanding, maybe pathologizing things that are just part of the range of human experience.
Yeah, that general concern. And Jonathan Waisu adds another point about context, specifically with conditions like schizophrenia.
What does he say?
That our predictions and even our understanding of someone with schizophrenia can be significantly affected by their social context. Biology isn't the whole story by a long shot.
It's always biology plus environment plus psychology.
Right. And Diane O'Leary goes even deeper into the philosophical bedrock. She suggests psychiatry often operates with an underlying assumption, even while sometimes denying it.
An assumption. What is it?
Property dualism. The idea that mind and body might be the same stuff, but mental properties are fundamentally different, distinct from physical properties.
Even if psychiatrists say they reject mind-body dualism.
O'Leary argues that this implicit property dualism persists and actually causes problems. She thinks our struggles to define mental disorder or figure out the best care models are linked to these shaky philosophical foundations about mind and body.
Wow, so our basic philosophy impacts practice.
Deeply, she suggests. And finally, Dominic Murphy brings in social constructionist theories.
Okay, how do they explain things?
They often try to explain behaviors that look pathological by pointing to, normal psychological mechanisms interacting with social norms and contexts, instead of immediately assuming a biological malfunction.
So the explanation lies more in the social world or normal psychology under pressure.
Often, yes. Murphy notes, though, that sometimes this perspective can lead to skepticism about mental illness itself, maybe by assuming the underlying psychology is always perfectly normal, which might downplay real distress or impairment.
Okay, so that's a lot of ground covered. Bringing this deep dive toward a close is just abundantly clear that disorder in psychiatry is not straightforward at all.
Not even close. It's this incredibly complex mix, isn't it? Biology, psychology, society, history, philosophy, it's all in there.
And the debates are clearly ongoing. There's no single easy answer, no universally agreed upon definition.
Absolutely not. And I think understanding the Understanding the different perspectives and the ongoing arguments is really crucial if you want to be well informed about mental health. Hopefully you've had some of those aha moments seeing the complexity behind the term.
Definitely. So here's a final thought for you, the learner, to maybe chew on. Given all these different lenses we've looked through today, the biological, the social, the subjective, the functional, the historical, what do you think are the most important things to keep in mind when we try to define and address mental health challenges?
Yeah, what factors weigh most heavily for you? It's worth reflecting on.
We really encourage you to think about the different viewpoints we explored.
And this deep dive, it's really just scratching the surface, a starting point. Maybe look up some of the experts we mentioned. Think about your own experiences or views on what makes something a disorder.
It's a fascinating and honestly a really important conversation to keep having.